Okay, students, I am going to give you a very quick recorded lecture. Please listen to this lecture in its entirety because at the end of the lecture I am going to go over some things you should probably focus on for the exam this weekend. Okay? So, so let's kind of run through this. Here are your learning outcomes for the chapter. This is all about STDs, okay? So first of all, HIV and AIDS. So we're all pretty familiar with that. The one thing I do want to point out to you all is when a person is exposed to the HIV virus, it spreads pretty quickly through the lymph nodes throughout the entire body within a couple of days. And the virus can be detected within 3 days of initial exposure. Probably want to remember that, okay? Now when HIV progresses to the AIDS syndrome, acquired immunodeficiency syndrome. And so when people succumb or die from HIV and AIDS, it's usually because of this immunodeficiency syndrome where they, like opportunistic infections is what gets them because their immune system has been totally compromised, okay? So we all are probably familiar with the transmission. It's sexually transmitted or through IV needle sharing, and really just anything where there's blood-to-blood contact, okay? It can be asymptomatic. However, if the patient does have symptoms, like they're very vague symptoms that you could probably relate to the flu, okay? So you can see those listed there. So our risk factors are listed here. So, you know, this is very preventable. We need to teach our patients safe practices. However, we do know that a lot of these risk factors, these patients have more problems than that they have to deal with. It's not just as easy as, oh, I'm just going to change my lifestyle. For these people, especially IV drug users, like they have an addiction problem that needs to be addressed, okay? History of prostitution, so, well, and it's just unsafe sex practices. So history of prostitution is you know, a pretty specific risk factor, but it's basically unsafe sex practices, okay? One thing you want to know as far as screening, there's these opt-out, opt-in options that sometimes patients are not aware of, so we really need to kind of educate our patients. So an opt-out testing is all patients will be tested, irregardless. So if they don't want tested, they have to actually decline it. They have to actually say that they do not want to be tested. Otherwise, everybody's going to be tested, okay? An opt-in testing is, this is not across the board, everybody's going to be tested. These patients must give consent to be tested. Otherwise, we will not do it. So opt-out is we're going to do it on all patients, irregardless. They must refuse it, or we're going to do it. And then opt-in is the patients actually have to give permission to be tested. Routine testing for women 19 to 64, so that's basically you know, the normal group of fertile group of women. So this is ACOG, American College of Obstetrics and Gynecologists. So we do test all pregnant women, and then routinely. So this is one of those things where if you come in for a prenatal test, or prenatal care, we're going to do the HIV testing unless you absolutely say to us, no, 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 don't do it. And then, you know, you want to screen people who are at risk, okay? So the screening tests are basically, if you've probably heard the ELISA test. So these are just screening tests. So remember what screening means. Like, if you get positive results, then you need to do more diagnostic testing, okay? So if that's the case, if someone tests positive on the ELISA screening test, then they will do the Western blot test, which is confirms or is diagnostic, okay? All right, now remember when I said in the previous slide that we can detect HIV, the HIV virus within 3 days of exposure, okay, and this says antibodies detected within 3 months. So that's the difference, where the virus can be identified within 3 days, but the process of the patient creating antibodies towards that virus, we can't detect those antibodies. That process doesn't occur, and we can't detect those antibodies for at least 3 months, okay? So make sure you know the differentiation between there. So of course you know there's no cure for HIV. However, there are antiretroviral medications that we can give. And so the goal of these is to just try to, well, one, decrease the copies of the HIV virus and preserve their immune function. And then that will help them fight off all those opportunistic infections, okay? And then we also, in the prenatal world, we also give women who are HIV positive these antiretroviral agents to decrease the possibility of transmission to the baby. Okay, so when they have them on these antiretrovirals, they'll be doing these testings to detect the copies of those viruses, and if they're below 1,000, then we feel like that the risks, we have decreased the risks enough to hopefully prevent transmission to the baby. All right, and of course there's a lot of psychosocial issues with women who are HIV positive that we need to kind of help them with. We may need to you know, refer them to counseling services, to support services, but you know, a lot of times these women that are HIV positive, they might even be homeless, they might have housing you know, housing problems, they might have not have jobs, they might be living on the street, and even if they do have a place to live, like the care that they need is really going to tax their financial status or their financial abilities. And then if they also have children, typically these women are single moms, and so they're taking care of their children by themselves, they're trying to work, and so they just need a lot of support, okay? And then also, of course, women who are HIV positive, they could also be at risk for candidiasis, HPV, herpes, and just bleeding problems in general. So they're at risk for all these other sexually transmitted diseases. Moving on now, chlamydia, most common bacterial STD in the United States. You know, a lot of times women are walking around and don't even know they have it, okay? And it's usually not until they're tested for whatever reason that we find out they do have this chlamydia infection. But if they do have some symptoms, you know, they could have some discharge, some breakthrough bleeding, some dysuria, and you know, you could relate those to all kinds of other things. So it's just very vague in general symptoms if they have any at all, okay? So, you know, if she's going to be having annual well women checks, we can be doing screening then. And we do need to do a PAP and collect some cervical cells to actually diagnose it, okay? And here are the tests that we would use to diagnose chlamydia infection. Now the treatment, of course, is antibiotics, and if she has a regular partner, then they need to be treated as well, because we can treat this woman and we can clear up her chlamydia infection, and then if her partner has chlamydia as well, and of course he probably does not know he has it, he'll just pass it right back to her. So it's best if she has a regular partner that that they both be treated, okay? So your standard treatment is doxycycline or azithromycin, and then if they have problems with those antibiotics, of course there's other antibiotics that they could be given. So just kind of review these and try to, especially the common treatments, the doxycycline and the azithromycin, please know those dosages, and at least know what other medications we could offer as alternatives, but you don't necessarily need to remember this dosing schedule. Okay, gonorrhea, second most common STD. Again, the woman can be asymptomatic with this infection, and if she does have signs and symptoms, they could be just very vague. So it wouldn't be like something she goes, oh, I got these symptoms, I must have gonorrhea. They're very vague. So hopefully when these women have these vague symptoms, they do go see their primary care provider to get tested for whatever. Okay. And one thing with gonorrhea, if these things are asymptomatic and the patient is not getting tested for these, then therefore not getting treated, this can progress to pelvic inflammatory disease and or infertility. Okay. So here is our screening or testing for gonorrhea, and then the antibiotics. And again, we do want to include the partner, because you can't clear the woman and not clear the partner, or she will contract the infection again. So Rocephin is the drug of choice. A one-time IM injection with azithromycin, a one-time PO dose. Okay. Well, this is supposed to say doxycycline, but it's a spelling error. Okay. So anyways, they do try for these treatments, they do try to do a dosing schedule that they feel the patient will comply with. So these one-time dosing schedules are really phenomenal options. When you get to where the patient has to take an antibiotic twice a day for 7 days or 10 days or however many days, or however many times a day, that is going to adversely affect them finishing the dosing regimen. Okay, so they forget to take a dose, or they forget a couple of days of dosing, and it's just not good. Okay, so one-time dosing is best option. Trichomonas is another STD, asymptomatic. However, if they do have symptoms, Trichomonas is their hallmark. Its hallmark symptom is this frothy vaginal discharge that is gray in color, and with a foul odor. Okay, she may have some ulcerations in her vagina or on her cervix when we do our exam that would lead us to this diagnosis. However, we do want to get do a wet mount or a rapid DNA test, and then treat the patient, and again treat the partner as well. So the treatment for Trichomonas is Flagyl, is the hallmark treatment, and if we can do this one dose regimen, that would be great. Okay. All right. Pelvic inflammatory disease is an infection of the uterus and fallopian tubes, or just the uterus or just the fallopian tubes, okay? Pelvic inflammatory disease. It does cause, if untreated, it does cause scarring and adhesions in the fallopian tubes, which can cause blockages, infertility, and then if, you know, partial blockages where this woman ends up having a tubal pregnancy, okay? Symptoms, she can be asymptomatic, but most of the time they have severe abdominal pain, or if it's not severe, it's just like a constant state of abdominal pain, okay? They can have discharge and bleeding, nausea and vomiting, fever and chills, okay? When we do their lab tests, they would have an elevated white blood cell count. They may have a low platelet count, and then they would have an elevated ESR, okay? The treatment is, there's a huge, so go to this website and look at the treatment options. There's, it's crazy, okay? So kind of want to familiar yourself a little bit with that treatment regimen, okay? Now HPV, the big one. Not the big one. So HPV is the virus that causes genital warts. However, a woman can have HPV and not have the warts, but warts are kind of, you know, if a woman has warts, that's the first thing you think of is HPV, okay? It's transmitted by skin-to-skin contact. So yeah, it can be transmitted sexually, but so wherever, so whatever part of the skin, so if it's not a sexual intercourse, but skin-to-skin contact of an area of the skin that is shedding the virus, then transmission can occur, okay? There's 100 different types. There's 30 different types that affect the genital tract. And some of the types affect the cervix. Anyways, these are found on the Pap test. A lot of times, you know, HPV virus really can't be cured. However, sometimes the woman's immune system can clear this virus, okay, within a couple of years, but and she wouldn't even probably know about it, okay. So it is usually asymptomatic. We need to do a Pap test to get cervical cells to diagnose it, unless she does have these warts, okay? And then we would yeah, she's probably got HPV and she'd need to go get a Pap test, okay? There is vaccines for it. The vaccines are three injections, IM injections over a 6-month period. So she takes her first injection, and then the second one, the second injection is given 2 months after the first, and then the last injection is given at 6 months. So Gardasil has been the vaccine we've been using, and it protects against just these specific types, 6, 11, 16, and 18, okay? And then here's our recommended ages of our guys and gals that we recommend getting the vaccine. And then the newer one, of course it's not brand new, but since Gardasil, we now have Gardasil 9. And the reason why they call it Gardasil 9 is because it also vaccinates against these additional types, okay? Now, as far as a patient who has HPV, warts related to HPV, you know, there's some things we can do to clear up those warts, but we might not clear them up forever. They will probably reoccur, okay? All right, herpes, virus 1, virus 2, so herpes 1 and herpes 2. So herpes 1 is associated with cold sores, and herpes 2 is associated with the genital lesions. So there's a primary infection where she can have flu-like symptoms, and then she can develop these blister-like lesions, okay? And then after that, like, these will resolve. The herpes virus is not cured, but it will resolve, and then she could have outbreaks. And usually the outbreaks are less severe, but they can, happen at any time. And people who live with herpes, they can kind of feel when it's coming on. They can relate an outbreak to, things like stress, being overworked, being overtired, things like that. And they can almost anticipate when they might have an outbreak, okay? Now, they can shed the virus even when they do not have lesions, so that makes it kind of scary, all right? So anyways, of course, we diagnose with, we actually do a culture to diagnose it. The treatment for herpes is not a cure for herpes, it's just a treatment to reduce the symptoms or prevent an outbreak. So antivirals like acyclovir is the one that's most commonly used, and it will, so if she is having an outbreak, she can take acyclovir, and it can kind of clear up that outbreak quicker than if she was not taking that medication, or she can be put on this acyclovir for a period of time to prevent an outbreak. So one example of that is if we have a pregnant patient that has herpes, somewhere around 36 to 38 weeks, we will put her on acyclovir to prevent an outbreak, because if she's not having lesions or an outbreak, then she can deliver vaginally. But if she has an outbreak, then she needs to have a cesarean delivery. So we put her on this treatment to hopefully prevent outbreaks, okay? There's some things that she can do to provide comfort when she is having an outbreak, and here's some other things that she can do to help alleviate her symptoms or prevent them, okay? So patient education is definitely, just like with any sexually transmitted disease, is we want to teach them like health practices, perineal care, safe sex practices, treatment of partners, and things like that, okay? And then, of course, these patients, might have a little emotional response to being tested positive for an STD, so maybe counseling or a support group of some sort might be beneficial if the patient seems to need it, okay? So syphilis can be treated, but if it's not treated, it can be fatal. Here's your transmission for those. Now, syphilis has kind of sort of like, well, not like herpes, but kind of similar. There's a primary infection, and there's a secondary and a tertiary infection, okay? So the primary infection happens, within 10 days of initial exposure, usually. They get this chancre, which is a painless ulcer, and it can last for several weeks, and then it resolves, okay? And so that's the primary manifestation. The secondary manifestation is occurs 6 weeks after exposure, 6 weeks after the appearance of the chancre, okay? So their signs and symptoms can be a little more severe, as you can see here, a little more involved. The primary infection is usually just the chancre, and some the secondary infection is a little more severe, okay? And then that resolves. And then the tertiary manifestation can happen a year later or more. And we start getting this thing called gummus. They're like tumor-like balls of inflammation. They can have joint disease. It will affect their neurological symptoms and their cardiovascular symptoms, and then that's when we can see these fatalities. Okay. All right. So here's our testing for syphilis. Pregnant women are all automatically tested for syphilis. And then, this is not a routine screening actually at a well woman check, okay? So this is just a screening, so if it is positive, of course we've got to do our confirmation test, and then our treatment is typically penicillin, okay? And I did not put the dosing regimen on here because it just depends on what stage they are in the infection and things like that. So here's your alternative, doxy and tetracycline, and these are given if the patient has a penicillin allergy. Okay, so now we're going to talk about, we're just going to run through hepatitis. Hepatitis is the leading cause of liver cancer, and the most common reason for a liver transplant. And there's several different types of hepatitis. There's the A, B, and C virus, okay, that we're going to talk about. So hepatitis A is an acute infection of the liver. It can be asymptomatic, or these people can have these vague symptoms. But the dark-colored urine or the clay-colored stool, and a patient who has jaundice, any patient who has jaundice is gonna have to think there's something wrong with their liver, so they can get tested. There's no specific treatment except for like symptom management, but there is a vaccine available. Hepatitis B, it's the most contagious. This can be fatal. This can be transmitted by sexual intercourse, but mostly we're kind of concerned in hospital about blood-to-blood contact. And then a fetal maternal transfer is a big, or transmission transfer is a big concern. All right. Just like any blood-to-blood virus that can be transmitted, so anything that needles or anything like shaving stuff, all those kind of things can be a problem. All right, so that's good there. Oops. Okay. So here again, symptoms, they can be asymptomatic, but if they do have symptoms, those are listed here, and jaundice, dark-colored urine, and clay-colored stools, those are big indicators, okay? Now, either, some people can recover completely from hepatitis B, but most, like 25%, will become chronically infected. We do screen all pregnant women. The screening markers can identify if the patient has an active infection, or if they're a carrier, or if they had a post-infection, okay? Vaccines are available, and then antivirals treat the chronic infection by decreasing their symptoms, okay? All right, hepatitis C is another blood-to-blood infection that affects the liver. There's 6 different kind of types of hepatitis C. But anyways, most people who have Hep C, they will become chronic carriers or have chronic infection, and then this will be really ruin their liver eventually. So they will be on, well, I'm sorry. So asymptomatic, and again, if they do have symptoms, look, dark colored stool, urine, clay colored stool, and jaundice. When patients see those things, they really need to think liver and get in to be seen. All right, so there is actually no vaccine for Hep C. Yeah, we do want to give them the hepatitis V vaccine if they do have Hep C, but that won't help their Hep C status. That'll just help prevent hepatitis B, them contracting hepatitis B. So the treatment for this is interferon, usually, and this is just to slow the progression of the effects on the liver, okay? Hepatitis D, I didn't list that in the previous slide. It says here that this is clinically indistinguishable from other types of hepatitis. So what that means is, as far as their clinical signs and symptoms, or what the primary care provider is observing, we can't really tell the difference. We need to do the serum blood test, okay? This is also asymptomatic, and then jaundice is one of those hallmark signs that they need to get in and get tested. So here's our counseling for women with hepatitis infection. We want to help them live healthy lives, but we want to really teach them about not spreading this to other people. So we need to teach them about safe sex practices. And then a lot of people with hepatitis, this is a lifelong problem. So, we need support. Refer them to counselors or support groups. There's lots of them around. Chancroid is another STD. These chancres or lesions that they have, they're kind of really distinctive. So they're very painful. They're covered with this like scaly yellow-gray material, and it can be, or it's usually on their labias. It causes their symptoms of dysuria, dyspareunia, and we do need to culture and biopsy it and then treat it with antibiotics. And here are the different treatment regimens. So hopefully a one-dose regimen with azithromycin and Rocephin combined would be great. Lymphogranuloma. So this is an infection of the lymphatics. It's caused by this chlamydia trachomatis. It's not the same as a genital chlamydia infection, okay? So this is an infection of the lymphatics, and it is spread through, breaks in the skin, or skin-to-skin contact with breaks in the skin, or via mucous membranes. So they can have some genital ulcers that will eventually go away, but then this progresses to their lymph system, okay? There are your symptoms, signs and symptoms. We do need to do a serology test, and then the treatment here is doxycycline. Look at that for, or emycin, okay? Okay, so granuloma, this is another ulcer lesions on the labia and perineum. So it's like an ulcer, like it's just a open area. It looks beefy red, kind of different than the chancres that have that scaly stuff on it. We need to do a biopsy, of course, and then here's the treatment for it. So doxycycline is used a lot in all these infections, okay? Pubic lice, or kind of what they call crabs, okay? Sexual contact or close person-to-person contact. These are found attached to the pubic hair, that can be, on hair of the body. So we kind of need to look everywhere. So the treatment is this lotion, and they do have, like, if it's in the hair on the head, they do have some sort of like shampoo-y thing, just like head lice, but so we'll give them this lotion, but we do need to teach them about lice control. So lice control, you can look in your text. So they need to wash all their clothes, all their bed linens in super hot water, okay? Or if they're things that can't be washed, then they need to put them in a Ziploc plastic bag for, I think it's like up to a couple of weeks, so that those lice and stuff do end up dying, okay? Scabies infection, I will let you kind of read over that. And then just the general education, safe sex, partner protection, genital health, all those kind of things you can kind of look over. All right, so now we will move on to the last chapter. Okay, so I'm going to only hit a few things here on this chapter. Here are your learning outcomes. Talking about HPV again, so this HPV, so this chapter is about cervical cancers, screening, and exams for, and the risk of HPV causing cervical cancer. So that's why we're talking about HPV again. HPV is a primary cause of cervical cancer. It can cause other cancers, okay? And again, remember, there's over 100 different virus types, and more than 30 types that cause genital problems. So, okay. So when we talk about the cervix, and we're doing all these biopsies of the cervix, you need to look at the, I didn't put the diagram here, the picture here, but do look over that on your text, and kind of go over, or kind of pay attention to these different cell types that cover the cervix, okay? So your squamous epithelial cells, and then your columnar epithelial cells. So the squamous cells, they cover the vaginal portion of the cervix. So you remember the cervix is the part of the uterus. It's kind of long. So you have the cervix that is on the vaginal side, and then you have the opening of the cervix that's on the uterine side, okay? So the squamous epithelials are the cells that cover on the vaginal side. The columnar epithelials are the cells that cover that cervical canal. So you remember the cervix is long, so that length is the actual cervical canal. Now, the place where the squamous and the columnar epithelial cells come together, that's just called that junction, okay? And then, a normal process, for the squamous cells actually being replacing some of those columnar cells. Okay, it's a kind of a normal process. So that's called squamous metaplasia. And then when that process occurs, so that little area between the old cells and the new cells is called the transformation zone. So you kind of want to remember that for the exam. All right, so there's continual cell growth and replacement. That is a normal process that goes on. It's a normal process influenced by hormones. It occurs more rapidly. This cell turnover occurs more rapidly during adolescence and during pregnancy, and because of this new cell growth, as these cells are growing and replacing, they grow from immature to mature. Of course, that is an area that is susceptible to cancer. Okay. So when we do our cervical screening or our cancer screening, we do the Pap test, okay? And so in the Pap test, we do collect cervical cells and send those for cytology to see if we can detect any cancerous cells, okay? Now, I do want you to pay attention and review the technique of collecting it. Now, this is not something that the nurse will not be doing the collection, but the nurse may, after the primary care person does do puts the speculum in, visualizes the cervix, and uses one of their tools to collect cells, then they may take that tool and hand it off to the nurse so that the nurse can prepare it on the slides or whatever medium that they're using, okay? So we do need to collect this sample before we do any type of digital exam. Excuse me. We don't want to be using a lot of KY jelly and do a digital exam. However, we can moisten warm water, the speculum to put in. That will not skew our results, okay? So once the speculum is put in, if there's a lot of cervical discharge, then we want to clean that off, because we're not looking at the discharge. We're looking at the cervical cells. So we need to clean off any excess discharge on the cervix, and then we can obtain our samples, okay? Like I said, we are going to use one of those tools, so depending on what part of the cervix they're wanting to sample, they might just use a spatula device or a paddle, or they may use a cervical brush or a plastic broom, whatever you want to call it. You can see the pictures of those in the text. And then the exocervix, so exo and the endocervix, so do look at your book for, do look in your text for where they're defining those. So the exocervix is the cervix that's in the vagina. They get the samples from that first, and then the endocervix, which is a little higher up, then they'll get those with the brush, okay? But then they need to immediately put their samples on their glass slides, and then fix it with a preservative. They need to do that like within 3 to 5 seconds, okay? Or those cells start to dry up, and then they can't, then that won't be a good test to look at for cytology. So just the liquid-based process, they collect the cells, and then they put it on their, they put it in an alcohol-based preservative, and in this preservative, like this little tube of preservative, like this will help remove the contaminants from the sample, and then the cells that they want to look at are filtered out, and then deposited on the glass slide, okay? So anyways, here are your recommendations for when to start cervical cancer screening. So you might want to remember that, okay? One thing you want to educate your patient about is, like, if you set up an appointment to have her pap smear, you know, we want to try to schedule it during her mid-cycle, and then you want to tell her not to do these things that are listed here within 24 to 48 hours of the actual testing, because those will skew your cells and your results, okay? So here again is some recommendations of when to do our cervical screening. This Bethesda system, so it's just kind of classifying. So when you do your pap smear and you send your cervical cell sample for cytology, and those cells have, or that pap smear has been determined to be abnormal, they will identify what kind of cells they're dealing with. So is it epithelial cells that they're having the abnormality for? And here are your different types of epithelial cell abnormalities. Are they those glandular cells? And here are those different types. Okay, so you can just review those. I am not except for the epithelial cell abnormalities, I do want you to kind of review those, okay, for your exam. Anyways, after you've had an abnormal pap, then they're, depending on the cells that they, so depending on the cells that were abnormal, they will recommend one or a couple of these different tests to kind of take more of a sample for cytology, okay? So please review these tests, and it would be a good idea, especially for the colposcopy and the endocervical sampling, that you kind of know about those tests. All right, hint, hint. Cryosurgery is another procedure that you might want to be very familiar with for your exam, okay? Laser ablation is another procedure that can be done for these abnormal cells, okay? So conization, you might want to know a little bit about conization, kind of review this procedure, and especially, let me look, conization, hold on. So the colposcopy, I told you you want to know about the pap test, the procedure, and how to prepare the specimen, the colposcopy, and then post endocervical sampling and post cryosurgery patient education. Please make sure you're aware of that education the nurse should be providing, okay? So HPV, so I'm trying to see anything that I need to point out again here. I do want to add that HPV is passed by skin-to-skin contact, so it can be through intercourse, but it's not just through intercourse. So just contact with the infected area of the body, skin-to-skin, even if there's no intercourse, that can pass the HPV virus, okay? So again, a review of the different types. Now, I did point out here the types that for the different types, their risk of causing cancer, cervical cancer. So 6 and 11 is very low risk. Type 16 can cause the squamous cell carcinoma. Type 18 can cause the cervical adenocarcinoma. And then other types that can cause cancer are these all listed here, okay? So just to kind of separate those for you. Here are your risk factors. No, these aren't risk factors, I'm sorry. So HPV may produce no symptoms. We find it during abnormal Pap test, which is a screening, and then we do the DNA testing to confirm what type of HPV we have, okay? So the Pap test, again, all right. So abnormal test results, Pap test results, they may have the genital warts as one of their signs, and then we could see cervical lesions. So they would have an abnormal Pap test, but they may or may not have genital warts, and they may or may not have cervical lesions. But these are things that we may be able to identify on clinical exam. Here are your risk factors related to HPV infection. Cigarette smoking. So why do you think cigarette smoking? Just because she's unhealthy? No, because cigarette or smoking causes cell damage. So that would allow those cells to be susceptible to an HPV infection. And then, you know, unsafe sex practices here, you can see, put them at risk, okay? So here is teaching that you would want to do with your patient, health education teaching. Here, again, I listed the HPV vaccines. The one I listed, Cervarix, can be an option, but with that one, with the Gardasil and the Cervarix, that's the one with the 3-dose regimen. Second one given at 2 months, the third one given at 6 months. The Gardasil 9, however, that's the one that treats for these additional HPV types. She'll get her first vaccine of Gardasil 9, and then the second one is only a month later, and then the third one is 6 months later. Okay. Now, again, we talked about genital warts. We can provide treatment to kind of heal up those warts. It can be medication that the physician and or patient applies, or the physician can do some sort of cryosurgery or excision or laser surgery to get those warts off. However, they may recur. Okay. So let me take a pause for a minute. Okay. Just kind of wanted to see where we were. Cervical cancer. So the majority of them are squamous cell carcinomas. Some of them, a few of them are the adenocarcinomas, and then we have the combined type, adenosquamous carcinomas. Cervical cancer can metastasize to the bladder, intestines, liver, and lungs. The one thing about cervical cancers is they do typically grow slow. So if this woman is getting her annual exams and discovering, abnormal cells, then we can treat it with 100% curability at precancer when we see the precancerous cells. Okay. So what's your risk factors for cervical cancer? Of course, HPV infection, cigarette smoking we talked about. So here's some other risk factors that you can review. So again, cervical cancers may be asymptomatic. However, here can be some very vague symptoms that can be related to almost anything. Okay, so we need to teach patients to be diligent about reporting abnormal signs and symptoms. Okay, so our workup once cervical cancer has been diagnosed is to see about any type of metastasis. Okay, so these are some of the other tests that we will do after we have diagnosed cervical cancer. Okay. They do stage cervical cancer like breast cancer or other cancers, stage 1 through 4. You can review these. These are pretty self-explanatory. And then treatment, of course, is going to be dependent on what stage of cancer they're in. And the treatment can be surgery, chemotherapy, radiation therapy, and biological therapy. Okay. Oops, wrong way. So they can use one or a combination of all of these, depending on their stage and what they think would be most beneficial for the patient. So anyways, here's your different surgical procedures. Again, I want you to pay attention to cervical conization. Chemotherapy is usually reserved for metastasis, or if the tumor is large enough, or if the tumor is large and they want to shrink it so that it would be easier to operate on. Okay, so here are your chemotherapy regimen and the side effects that you want to educate your patient about. Radiation therapy. Here is your regimen for radiation therapy, and then educate your patient about these side effects. When we're doing radiation therapy, we can do external radiation or internal radiation, so kind of review those. And then the biological therapy is to kind of boost the patient's immune system, and we usually use interferon with that, or interferon for that. So educate your patient about these side effects. Okay. All right. So the last thing I want to review with you before I close is what to focus on for your exam. So you might want to look at intramenstrual bleeding. And know a little bit about what that means as far as when instrumental bleeding is. Okay, look at your meds for that you would recommend the patient take if she's having very painful menses, and why those medications are beneficial. Okay, look at the medications to treat bacterial vaginosis. Review toxic shock syndrome, and review polycystic ovarian syndrome. Okay. Review the signs and symptoms of ovarian cancer. Review endometrial cancer and what kind of things are linked to endometrial cancer. Look at endometriosis, the treatment for endometriosis, and then what patient education you will give the patient in relation to treatment. Look at yeast infection, and if a patient is suffering from recurrent yeast infection, so she gets a yeast infection, she takes over-the-counter medications for that, resolves her yeast infection, and then like a few weeks later she just keeps getting them. They keep resolving and she keeps getting them. Why? What would you look at about the patient? What kind of testing would you do that might tell you why this patient is having frequent yeast infections? Review HIV. Review specifically opt-out testing, and when we can see the virus, when we can detect the virus, and when we can detect patient antibodies to HIV. Review treatment for chlamydia. Review treatment for trichomonas, and what patient education you will give them regarding treatment. Review the signs and symptoms of syphilis and the treatment. Review pelvic inflammatory disease and the clinical signs and symptoms of that. Review the treatment for gonorrhea, and also do we treat something? If a patient tests positive for gonorrhea, do we just automatically treat them for something else? And if we do, what is it? Make sure you know about the cells of the cervix and what the transformational zone is. And again, review the Pap test, the procedure, and specimen collection. Review colposcopy, post-endocervical sampling, patient education, post-cryosurgery, patient education. Review HPV testing results in relation to low-grade intraepithelial lesions. Review HPV preventions. In addition to the vaccine, okay? Review the signs and symptoms and screening for cervical cancer. Review the prognosis for localized cervical cancer. Review the post-LEAP procedure patient education. Review brachytherapy for cervical cancer. Review menopause, what defines menopause, the hormone therapy for menopause. Review compound bioidentical hormone therapy. When you're reviewing menopause and perimenopause and postmenopause, make sure you understand what the climacteric period is. Review Kegel, your patient education for Kegel exercises. Review, so for menopause and the treatment of Qigong and energy flow and meridians, where a patient might find information and or providers, practitioners who support that type of complementary therapy. Review over-the-counter treatment options for postmenopause symptoms, perimenopause symptoms. Understand the patient's fertility or lack of fertility during the perimenopausal period. Review the patient education with the Osphena treatment and with the Fosamax treatment. And if you review this information that I've just went over with you, you should do well on the test. Okay. All right. Don't forget your test is this weekend. And if you have any questions or concerns, text me or email me. Okay.